Great. So our presenter today is Dr. Josephine Rioki, as you can see on the screen. Dr. Josephine Rioki is a lecturer in the University of Nairobi at the Department of Human Pathology, Faculty of Health Sciences. Dr. Josephine Rioki holds a Bachelor of Science degree in Medical Laboratory Sciences. Dr. Josephine Rioki also holds master's degree, actually 2 master's degrees. That is quite commendable in molecular medicine and clinical cytology. Dr. Josephine Rioki also holds a doctorate of philosophy degree in clinical cytology. And with this, you can actually see the prowess and the experience that Dr. Josephine Rioki is coming to present with us in matters cytopathology. So as stated, the topic is from cells to clues, the diagnostic power of cytopathology in infectious and non-infectious conditions. It's my pleasure now to invite our presenter, Dr. Josephine Rioki. Karibu sana, daktari.
Thank you so much, Osimbo, for that wonderful introduction. Good evening, good afternoon, and good morning, depending on your time zones. We appreciate that the fact we come from different countries. So depending on your time zone, greetings from my end. I'm here to discuss with you on a very interesting title that is From Cells to Clues, the diagnostic power of cytopathology in infectious and non-infectious conditions. For the interest of time, I will not introduce myself. I've already been introduced. So I'll just go straight to the stuff for today. This is my outline. We are going to look at the objectives. We are going to look at the introduction to cytopathology, cytological manifestations in viral infections, bacterial infections, fungal infections, parasitic infections, non-infectious agents and cytological changes, limitations of cytopathological techniques in clinical diagnosis. Then we shall look at the advanced diagnostic techniques that are used alongside cytopathology when you want to increase the diagnostic accuracy. Then we shall have a closure, that is a conclusion. So by the end of this session, it's expected that we shall be able to understand the role of cytopathology in the diagnostic process for infectious and non-infectious diseases. Non-infectious diseases, we have even cancer being one of them, but today I'm not going to discuss about cancers. We shall have another forum, if time allows, to do discussions on how we diagnose cancers at a later webinar. The second objective is that we shall be able to identify key cytological features associated with common infectious agents, for example, viral, bacterial, fungal, and parasitic, and non-infectious conditions, for example, the inflammatory conditions. The last one, we shall be able to recognize the strengths and limitations of cytopathological techniques in clinical diagnosis. Cytopathology is a subspecialty of anatomic pathology that deals with the diagnosis of diseases at cellular level. Some other authors say that cytopathology is a branch of pathology that entails diagnosis of diseases at the cellular level. This means that we identify disease conditions under the microscope, the light microscope, after staining our slides. and it is widely used in the screening, diagnosis, and monitoring of diseases through examination of exfoliated or aspirated cells. Exfoliated cells are those cells that are obtained through a natural process or spontaneous process whereby the cells shed to the body cavities. Aspirated cells are obtained when a surgical or a clinical procedure is done. For example, if a patient is having a swollen lymph node, an aspiration is done, which is a fine needle aspirate lymph node, and we are able to collect cells for cytological evaluation. We have got quite a number of techniques when it comes to cytopathology. The common ones including Papa Nicolau smears, which is commonly referred to as PAP test, and we have fine needle aspiration cytology. In fine needle aspiration cytology, we usually do this technique in palpable masses, and even those ones that cannot be palpated. That's what is done is usually the ultrasound guided FNSC or fine needle aspirate. So you can do a fine needle aspirate on masses that you can feel when you are palpating, or those masses that you cannot palpate, but you have to be guided by an ultrasound. Then we have bronchial washings, quite a number of such. We have urine cytology, we have sputum cytology, and many more others. I've just mentioned examples. Then why is it that we are interested in cytopathology? Actually, cytopathology is one of the techniques that has not been utilized locally because we are not exposed most of the time on what the role of cytopathology entails. But as we are having a demand on early and accurate diagnosis, that's why we thought that we should be able to discuss this aspect with you so that we can come up to one front where we understand what cytopathology is and what it entails. And this technique is very useful, especially in resource-constrained settings, Kenya, of course, being one of them. And it's very important for us as laboratory professionals to be able to have the ability to interpret cellular changes that are essential for diagnosis and patient management. When it comes to diagnosis using cytopathology, it's not a very difficult when it comes to identification of infectious and non-infectious diseases. Any other laboratory professional can be able to identify the cellular changes or the microorganisms for them to be able to make a diagnosis for patient management. So the advantages there is that one of the advantages of cytopathology is that when we are using this technique or cytological techniques, we get rapid results. So we have a shorter turnaround time of giving the patient results. A patient can get results within 30 minutes, 1 hour, or within a day, depending on the personnel that are available, in relation to histopathology, where you'll take 4 days, 1 week, a month to obtain the results. Another advantage is that when you're using cytopathology as a technique, it is minimally invasive. So in relation to histopathology, cytopathology is minimally invasive because of the sample collection process. You realize that an example maybe is a pap smear collection. It's not an invasive process. Somebody can obtain a pap smear. A gynecologist, a gyna nurse can be able to collect a pap smear. And some other places, even the laboratory professionals can also collect pap smears. So it's minimally invasive. And that's why we say that that is one of the strengths of cytopathology as a discipline. In relation to histopathology, cytopathology is cost effective, meaning that patients spend less to get results and diagnosis that can have a positive impact for their management. And this technique is also useful for both screening and diagnosis of diseases, various diseases, cancer being one of them. Initially, we used to think that cytopathology, you only deal with cancer diagnosis. No, we are going to see on how we can use cytopathology to diagnose other disease conditions, not necessarily cancer. The next one is that the repeat test can be done without major risk to patients. One of the examples to explain that point is that, for example, if you are having, you have stained a slide and you find that during microscopy, you did not do it well. Either it's too hyperchromatic or hypochromatic or something amiss is happening. You can always do what we call destaining and processing. Then you are able to recover your slide again for analysis. So it's easy. It's not like you are going again to reprick the patient to get a blood sample or to collect CSF from a patient. So most of the cytopathological techniques, you can be able to have a repeat test done to the patient, and that will not cause a major risk to them. Let's look at the basic structure of a cell. We are talking about cytopathology. Cyto basically means cells. The pathology is a disease process. So cytopathology, we are looking at the disease processes using cells or in cells. But it's important to understand the basic structures of a cell. And by definition, cells are basic units of life. So if our cells are healthy, then the whole system is healthy. If our cells are not healthy, then there is a problem with our system. When it comes to cytopathology, what usually is done is that we look at the morphology and be able to make a diagnosis. So it's important to note that when we are interpreting cytological material, we will always look at the cytoplasm, we will always look at the nucleus and the staining characteristics for us to be able to say if a patient is having an abnormality or not. So that is just a basic structure of a cell, so that we are not looking at the gritty details of a cell or the molecular parts of a cell. It's just the basic, what you see under the microscope. So this pictogram is just showing a healthy cell and an abnormal cell. For this case, I used an example of a cancer cell in this case. So from the first, from the healthy cell, you can see that we are having superficial cells with a small nucleus, abundant cytoplasm. And when we go to the second cell, we are having some these cells. Yeah, tadpole cells, hyperchromatic. You will just know, even if you are not trained cytologist, that there is a miss. There is something wrong with such cells in relation to what we are seeing as a healthy cell. So we have features that we look at for us to be able to know that this is a healthy cell. And for a healthy cell, it has to have smooth nuclear membrane, normal nuclear cytoplasmic ratio, and regular distribution of chromatin. So if the three of them, and we have more other features that we usually also look into to guide us in the diagnosis or to give us a clue to what diagnosis is. So I've just mentioned a few. So for example, in a healthy cell, if we can look at this, this nucleus, it's relatively smooth, but when you look at the second one, it's not smooth. It's having some angulation thereabout. So the cell membrane is not smooth. And I may not be able to take you through the chromatin, but if using the lower portion of this cell, I cannot be able to tell you that it is hyperchromatic or hypochromatic. But if we look at the upper portion of that cell, so here I only picked one. So the upper portion, you can see that there is hyperchromasia. So we also look at the staining intensity of a cell for us to be able to tell if a cell is healthy or not. So then what happens to the cells when they encounter an external stimuli? For example, when cells encounter infectious agents, they usually undergo characteristic morphological changes that can be identified through cytological examination, that these particular cells depict some characteristics that are picked during microscopy, and the analyst is able to say this patient is having this condition or not. And these changes include alterations in the nuclear morphology, the cytoplasmic modifications, and the presence of specific inclusion bodies or organisms within the cells. The inflammatory response triggered by infectious agents usually lead to recruitment of various immune cells. For example, neutrophils are recruited, lymphocytes are recruited, macrophages, and plasma cells. And each of them will display a particular cytological feature or characteristic that will give us a clue to a condition or a disease process. So we are having the cells the way they are normal, and when they are affected, the effects that we see under the microscopes, under our microscopes, then give us the clues about the nature of chronicity of the infectious process. For example, we can be able to say that a patient is having acute inflammation by virtue of looking at the cells under the microscope. So if we have so many neutrophils, we will know that the patient is having acute neutrophils. But if you are acute inflammation, sorry. But if we have macrophages, we have plasma cells, then those features will automatically lead us to knowing that this patient is having a chronic inflammation or chronic process. And before we come to the nuclear changes, the cytoplasmic changes, it's important also to know that sample collection and preparation is mandatory in our laboratories and or in wherever the patient is being attended from. And collection of cytological material, most of them, the brushings, the FNA aspirations are usually carried out by physicians or doctors, apart from other samples like sputum or urine, where a patient is told to collect, that is self-collection. Majority of the samples are usually collected by a clinical team or the doctors. And when we get those specimens, it's important to know that we are supposed to do a proper sample preparation before we smear, we fix, and staining. Before the specimen now goes to the end product, that is now the examination and the generation of a report. So when we get the sample, we have to know how to archive or store the sample in the right temperature, right conditions, for us to be able to get accurate results. Ideally, we just get a smear. If it's a specimen, you do. If it's a pleural fluid, you'll have to spin and get the deposit, do a smearing, fix it using appropriate fixatives, and you stain using an appropriate staining technique or method, and then the same slide is evaluated microscopically. So then what are the factors that would affect the sample quality and diagnostic accuracy? So with cytology, if you do not have a good quality sample, you will not get a diagnostic accuracy. You may get false positive, false negative report. So it's important to be cognizant that we have factors that can impact the end result of what we do. And these factors can affect the following factors can affect the quality of the sample and the accuracy of the diagnosis. For example, in the sample collection technique, if the skill and experience of the person collecting the sample can significantly impact the quality of the sample. So if somebody is not skilled enough to be able to collect maybe a CSF, we will not be able to get an accurate diagnostic report by the end of the day. What about sample preparation? The preparation technique used can affect the morphology of the cells and the accuracy of the diagnosis. So if we do it wrong during the preparatory process, it's garbage in, garbage out. So if you do it well, we get good results. If you do it badly, we don't get good results. The other factor is on sample storage and transportation. Here, Improper storage and transportation can lead to sample degradation, and this can affect the accuracy of the diagnosis. So it's important to ensure that when you have collected the sample and you are transporting this sample to the laboratory, that it is done appropriately so that the cellular morphology is maintained. We are looking at the cell membrane, we are at the nuclear membrane, we are looking at the cytoplasm and the nucleus. So if the nucleus has degenerated, we will not get an accurate diagnosis to our patients. So what are then the principles of cytological interpretation? How do we come up with our reports? So the principles include the following, that we look at the cellular morphology, and in here, we just look at the shape of the cells, we look at the size of the cells, we are looking at the structure of the cells, we are looking at the staining characteristics. Is the staining characteristic, is this cell hyperchromatic? Is it hypochromatic? And if it's hyperchromatic, and we've done the correct staining procedure, then there is something amiss. That is the time now we start looking for features of malignancy or features of a cell showing that it is either inflamed or it has got, whether it's inflamed or it's not healthy for this case. So sometimes we have reactive changes, and that we'll have to see them from the staining characteristics of the nucleus. Then we also look at the cellular arrangement, how our cells are arranged in relation to each other. When they're having that cohesion, we know there's no problem with the sample. But when the time we find that the cells are not cohesive enough, we know that outrightly there is a problem. So those are the cytomorphological aspects that we look at for us to be able to make a diagnosis. So let's look at diagnosis of viral infections. I know that we do a lot of virology, and also when we come to cytology, there's a lot of also virology. So we have cytology is also related to other disciplines besides histopathology or anatomic pathology. So we have viral infections and others that we are going to see how we make a diagnosis in a cytology laboratory. So viral infections usually produce characteristic cytopathic effects that are identifiable on cytological examination. And these include the following. Number one, the nuclear changes. So viruses often cause enlargement of cell nuclei. So we are not going to have the normal cell nuclei that we saw previously. We are going to have it enlarged. And again, we can also observe formation of multinucleated giant cells and the development of characteristic inclusion bodies. So an example here is that in herpes simplex virus, we usually see intranuclear inclusions with ground glass appearance, while cytomegalovirus produces large intranuclear inclusions surrounded by clear halos. So we have different types of viral infections that we can be able to diagnose using cytopathological techniques, but I've just given an example of a few. So when it comes to the cytoplasmic alterations, some viruses cause specific cytoplasmic changes, including the formation of cytoplasmic inclusions, alterations in organelle distribution, and changes in cellular shape and size. Remember the slides that I showed you, the previous one, which was a basic structure of a cell, that if you see a miss with the cytoplasm having those inclusions, they are pointing towards, or they're giving you a clue towards a specific diagnosis, and in this case, a viral infection. So cytology is about seeing and feeling. We usually say we cannot talk about cytology if we are, or cytomorphology if we are not seeing. So we have herpes simplex virus infection. I've tried to give quite a number of examples so that you can be able to understand what we mean. And herpes simplex virus cytopathic effect is most often caused by herpes simplex type 2 and sometimes herpes simplex type 1. And the affected cells are characterized by mono or multinucleated cells. Mono, one cell that is having issues, or multinucleated, more than two cells more than two nucleus in a cell with ground glass chromatin, chromatin margination, and nuclear molding. This is another example of how you would see what you would see under the microscope. So the example number one, we are having margination meaning that the chromatin is pushed towards the periphery of the nuclear membrane, and then it's leaving some clearing around the nucleus. So the ground glass appearance is what we are seeing. If we look at this cell, we are having more than this, about 3 nuclei in one cell. These are 2 in one cell. So these are features of herpes simplex virus infection that is on cytopathology. Sometimes they present themselves in different ways. It's not always the same. If you look at different textbooks, or for those of us who have done research, you will find that the way they present themselves is not always the same. So you will have to be careful to know what it means. And we usually say cytomorphology of herpes simplex virus, we have the 3 M's. We talk about marginated chromatin, and I've mentioned that margination of chromatin is that there is the chromatin content which is pushed to the nuclear membrane, leaving a clearing around this region. And also, this is a multinucleated cell. This is what we are calling multinucleated cells, margination of chromatin, and nuclear molding, and possibly eosinophilic intranuclear, what we call Cowdry A inclusion. So you can see that we are having some inclusions in the cells of interest. In the background are inflammatory cells. Of course, we've talked about inflammatory response towards infectious agents, that white blood cells or neutrophils are usually recruited. So we are having neutrophils in the background, meaning that this is not chronic infection. Yes, it is an infection due to herpes simplex, but it is not a chronic one. It is rather an acute infection because of the background inflammatory cells, which are the neutrophils. Another example of herpes simplex virus cytopathic effect, still the same cells showing the margination of chromatin, So all these are cytopathic effects of human papilloma virus. Not human papilloma virus. This is a herpes simplex virus. Sometimes HPV comes because it causes cervical cancer. So this is herpes simplex virus. These are the cytopathic effects of herpes simplex virus. Another photomicrograph. Then we see another. I've mentioned that sometimes they don't show the same. So this one, if you're not very careful, you can always miss it out, but we still have the inflammatory background. This is multinucleated. It's a multinucleated cell having more than 2 nuclei in that particular cell. So all these are features of herpes simplex virus, and that is what is usually diagnosed on cytopathology. So when it comes to another virus, this is a cytomegalovirus, we also see cytopathic effects in the cells under the microscope. Behind, in the background, we are having this is blood or red blood cells, and each cell has a large basophilic intranuclear inclusion that is surrounded by a halo. The cytoplasm contains multiple small basophilic inclusions as well. So for those of us who have been in the field more, they can be able to see the basophilic inclusions that we are talking about. But for this session, we are just interested to show you that this is how a cytomegalovirus affects the cells, and therefore this patient is having cytomegalovirus infection. We can be able to show, or it can be diagnosed using cytopathological techniques. Another example there is this is another pictogram showing CMV, which is of course a member of the herpes virus family. And we call this an all's eye. I've never seen a all, but the people who have seen an all, they usually say, oh, surely this looks like an all's eye. So here we are having a satellite cytoplasmic inclusion. So when you see such kind of feature in cytology, it gives you a clue to know that you're dealing with cytomegalovirus infection. So here we are talking about human papillomavirus cytopathic effects. One of the HPV, one of the human papillomavirus actually is a menace in the country and even external countries or international countries. So it's a global concern because it causes cervical cancer. And we have different types of human papillomavirus, over 200 types of human papillomavirus, among which we have high-risk types and low-risk types. Low-risk types usually cause papillomas or condylomas, but high-risk types are the ones that are associated with cervical cancer. So if a patient is having an infection with human papillomavirus, high-risk type, that patient is likely to develop cervical cancer at one point in their lifetime. However, there are those with the strong immunity. If a woman is infected with human papillomavirus, there are those that regress spontaneously, especially if a woman is pregnant, and there are those that will persist. So it is the persistence of the human papillomavirus that we get worried of, because if it persists, then it means that most likely a patient may develop cervical cancer. So when we say that a patient is having a low-grade squamous intraepithelial lesion, I didn't want to go to those premalignant lesions, but sometimes when we are talking about human papillomavirus, you get yourself again going to the cancer and the premalignant cancers. So this is a cytopathic effect of human papillomavirus infection. So when human papillomavirus infects a cell, these are the things that it will cause. And this cell is what we call a coilocyte. So there is a lot of abundant cavitation or halo around the nucleus, and this cell is more than one nucleus, so we have binucleation. So by the time a woman is told that you have a low-grade squamous intraepithelial lesion, you have a high-grade, you have cervical cancer or invasive cervical cancer, they will have seen the cytopathic effects of human papilloma virus cytologically. So we have presence of coilocytic cells with perinuclear halos and nuclear tepia. Nuclear tepia, there is a mild hyperchromasia. If you look at this, hyperchromatic, then we are having binucleation, and the nucleus is not smooth as what we had seen initially. So there is a lot of some mild nuclear irregularity there. So those are the things that we look at for us to be able to say that a patient is having a low grade. So this is what is usually, and there's a lot of research. People are doing a lot of research on human papillomavirus, and this is what they usually want to see, especially when they are doing cytology or cytomorphological aspects. So what about bacterial infections? I've given you examples of viral infections and what we usually see, and examples of the same. Now we look at the bacterial infections. So are they different? So what do we see when it comes to bacterial infections microscopically? So bacterial infections present with distinctive cytological features that help distinguish them from other infectious processes. For example, in acute bacterial infection, this typically shows abundant neutrophils with degenerative changes, including nuclear swelling, fragmentations, and the formation of toxic granules. And when it comes to chronic bacterial infection, this is when long-standing bacterial infections may show a mixed inflammatory infiltrate with lymphocytes, plasma cells, and macrophages. So when we see lymphocytes, when we see plasma cells and macrophage, they give us a clue of the diagnosis. We say this is a bacterial infection. We may be specific or non-specific. So if you don't see a microorganism there, but you've seen lymphocytes, plasma cells, and macrophages, then you'll just report chronic bacterial infection, non-specific chronic bacterial infection, because you don't know which bacteria is responsible for the type of inflammation or for the type of lymphocytes and plasma cells and macrophages that you are seeing. So you just have to say non-specific infections. You are not specific. But if you see a bacteria, for example, if you're seeing Neisseria gonorrhea, you can be able now to say the inflammation is due to presence of Neisseria gonorrhea and any other. By the way, with the cytopathology, you can also demonstrate the presence of Neisseria gonorrhea and many more others, but I didn't give that as an example. So we look at one of the examples of a disease that is caused by Gardnerella vaginalis, that is bacterial vaginosis. I saw that we had a presenter that I was following, and I was able to see they were talking about clue cells. Yes, clue cells can be seen on gram stain, and clue cells can also be seen in cytopathology. So in cytopathology, this is how beautiful these clue cells look like under the microscope. It's beautiful because we are seeing different colorations, but it is a problem to a patient. So presence of clue cells would indicate that the patient is having bacterial vaginosis. And these are coccobacilli. These are coccobacilli that are laying on our superficial cells. And the appearance there is what is described as a shag rag. So cytomorphology, you must always say what you've seen for you to be able to say that it is bacterial vaginosis. You have to describe the cells. So when you are describing, you will talk about the appearance of what you see. It is not the clear superficial cells that we usually see, but these ones are having coccobacilli on top of the cells. Of course, it's important to note that bacterial vaginosis, one of the symptoms is having a foul smelling or fishy discharge, and patients will also complain of itching. Okay, so another example is chlamydia trachomatis infection. This is caused by chlamydia, a bacteria that acts like a virus, and the organism infects immature cells, and some case a high-grade dysplastic cells. So sometimes the cells look like dysplastic and yet they are not. But on cytology, this is what we usually see. And every analyst, be it a cytologist, a pathologist, or a cytoscreener, they will always describe the cell before they say that a patient is having chlamydia trachomatis infection or not. Okay, again, another example of chlamydia. So again, you can see this is chlamydia, cytopathic effects caused by chlamydia. And I had another example here. If you see this is chlamydia. So this patient is having infection with chlamydia trachomatis. Another example here on a bacteria is Actinomyces israeli, or sometimes we call them Actinomyces species. Because with cytology, we don't give the species because you have to do biology, not biology, microbiological analysis for you to be able to give the species of the microorganism. But we just say it's Actinomyces species. So Actinomyces israeli is a bacterium seen more commonly in cytologic smears from patients with intrauterine devices, that is IUCD, which is a form of family planning method, and it is characterized by the presence of woolly aggregate of bacteria. Woolly aggregate is like wool, and with filamentous running out of filaments running out of the clamp. So you can see there's the filaments. I'll be able to show you good filaments in the next slide. So the filaments that we're talking about here, if you are very keen enough, you can be able to see that we are having some thread-like. So this is a woolly substance, actinomyces, and at the edges you can see some thread-like, what we call now filamentous bodies coming out of the main body. So whenever this is seen in a pap smear, we usually report presence of actinomyces. So the patient is having an infection with actinomyces species. And this any other person can do, whether you are a specialized cytologist or a laboratory professional. You can see that they're the same things that we do, but maybe we've not been keen enough to be able to make such diagnosis. So we come to the fungal infections. They are not also left out. So fungal organisms display characteristic morphological features that make them identifiable in cytological specimens. So examples that I've given are yeast forms. And in this category, we are having an example of Candida species, which appear as a budding yeast with pseudo-hyphae and true hyphae, while Cryptococcus usually shows encapsulated yeast with characteristic thick capsules. We'll be able to see an example of a Candida in that category. The other category is filamentous fungi, and an example here is Aspergillus, which causes aspergillosis. So we are able again to be able to tell that this is Aspergillus and it is not Candida. And we also have dimorphic fungi, organisms like Histoplasma capsulatum, which may appear in different forms depending on temperature and host conditions, requiring careful morphological assessment for accurate identification. So when it comes to dimorphic fungi, we have to be extra careful for us to be able to know that we are talking about Histoplasma capsulatum or something else. So when it comes to fungal infections, we also have other tests that we do to back up our cytological diagnosis. So Candida species is one of the fungal fungi, that causes fungal infections in women, quite common. So most of the women will always complain of itching vagina, having a white discharge. And when you do, we usually for microbiology, they will also demonstrate this organism when they do a gram stain. So when it comes to cytology, when we stain using Papa Nicolau, we are able to see the fungal elements. So we are seeing the budding here, we are seeing the pseudo-hyphae for us to be able to say that this is a fungal infection. So when we see them, we also report, and we usually say Candida species. We don't say Candida albicans because we have to do a germ tube test for us to be able to speciate the species when it comes to Candida diagnosis. And also for us to be able to give a description to convince the person who is looking at the reports, you have to describe what you are seeing again. So they stain pink to gray brown. Color, we may not be the same when it comes to color identification, but we are supposed to say that they look pink or grayish brown. What about aspergillosis? Yes, we also are able to demonstrate the infections that are caused by, or to diagnose infections caused by Aspergillus species. And Aspergillus species reveals regular, relatively slender 3 to 6 micromium hyphae, which dichotomously branch at 45 degrees and which have distinct septates. So if you look at the angulation here, this is what we are calling 45 degrees. So this helps us to be able to distinguish Aspergillus from Candida infections or Candida species. And the fruiting body is composed of conidiophores and club-shaped vesicles covered with a row of phyalites, and aspergillus, when seen in conventional cervical smears, they usually represent as a contaminant. If we see aspergillosis in a pap smear, they are usually considered as a contaminant. Okay, so another aspect of Aspergillus species, we can be able to see that body, which is a characteristic of Aspergillus species. So different presentation. So when you're doing cytology, you must be able to know the normals. You have to know to describe distinctly and say this is what you saw. Then we have another fungus here, which is Alternaria, which is commonly seen in conventional cervical smears. This is a snowshoe-shaped fungus with both longitudinal and horizontal septation. You can see the septations. And appears as a brown structure. It may appear to some people, they may think that it's an artifact when it is not an artifact. When you see the septations, you are able to know that you're dealing with a fungi, which is Alternaria. So I've said about fungal infection, identification or diagnosis on cytopathology. I mentioned that we usually back up with other tests. So we have special techniques or staining techniques for fungal identifications besides the cytomorphology. So if we think that we are not very subtle with the diagnosis that we have gotten, we go forward and do special staining. So we can use periodic acid SCIF, PAS, which will highlight the fungal cell walls and giving a pink magenta color. Then we are able to say that this is a fungal infection. We can also use Grocott methanamine silver, GMS, to stain the fungal elements, and they usually stain a black against a green background. And we can also use Calcofluor white, which will provide fluorescent staining of fungal cell walls. And that when you are using this kind of stain, you'll have to use UV light. What about parasitic infections? Yes, we can also be able to cytologically diagnose or detect parasitic infections. For example, protozoan parasites infections. Protozoan infections can be identified through characteristic morphologic features. So, for example, Trichomonas vaginalis usually shows characteristic pear-shaped morphology with flagella and undulating membrane in gynecological cytology specimens. We also have Entamoeba histolyticum, which will demonstrate typical amoeboid morphology with ingested red blood cells in an appropriate clinical context. And we also have Giardia lamblia, which can also be demonstrated. So for Giardia lamblia, you see a falling leaf motility and distinctive morphology in duodenal aspirates. So duodenal aspirates are one of the specimens that we are handled in cytology laboratory. So sometimes the patient is not having duodenal cancer. The patient could be having an infection with Giardia lamblia. And when the specimen is brought, they are acquiring cancer, but the cytologist is able to pick it out and say the patient is not having duodenal cancer, the patient is having a parasitic infection. And we have helminthic infections, that is parasitic worms and their eggs can be identified in various cytological specimens. And for example, here is a schistosome eggs or ova of Schistosoma hematobium and the likes. So they display species-specific morphological features, including terminal or lateral spine in urine or stool cytology. So we know that the ones that you identify in stool are having a lateral spine, and the one that is usually found in urine is lateral spine. So we have lateral spine, and we also have the lateral spine and terminal spine. That will be able to tell you the kind of schistosoma species that you are looking into, or what you are getting on microscopy. So the Trichomonas vaginalis infection, again, to show you a photomicrograph, and it's important to note that Trichomonas vaginalis infection is caused by a parasitic protozoan we have already mentioned, characterized by the presence of gray ovoid structures with hypochromatic nuclei. The gross appearance of the cervix resembles a strawberry. If you are to collect a pap smear from a patient who is having Trichomonas vaginalis infection, what you would see on the cervix visually is that the cervix looks the color of strawberry. So it's strawberry resemblance. That is the clinical pattern of strawberry cervix. People talk about strawberry cervix because it appears like it has some gross appearance that looks like a strawberry. And okay, yeah. So here we are looking at this. That's very difficult for you to be able to see, but we are having a dirty background. With Trichomonas vaginalis, when we are having a pap smear and we are evaluating the same, and you get a slide which is dirty like this one. This is a dirty slide. You just have a clue that there could be Trichomonas infection, the Trichomonas vaginalis. So what you start now looking at too is that you screen critically, looking for those small Trichomonas vaginalis, Trichomonas vaginalis, because you may not even be able to identify them. But here is one of them. Here is one of them. I'll show you another pictogram, which will be showing you the best of them, but it's important to note I used this one so that we can see that in Trichomonas vaginalis infection, we have a clue. It's a dirty background that is giving us a clue to what we anticipate. And these Trichomonas vaginalis, they usually like staying at the peripheries of the superficial cells. Cytomorphology of Trichomonas vaginalis. So what we look at, we are having all these are Trichomonas vaginalis arranged there. It's like they are having a party. No? So trick parties, it's like they're having a party. We are assuming that this is a table and they are all arranged here around. So this is a squamous cell, but now we are having the Trichomonas, the chicks, arranging themselves around that particular cell, forming what we call trick parties. It's like they're having a party. All these are tricks. There are quite a number in this slide. So they measure 15 to 30 micrometers long. They are pear-shaped and pale, eccentrically placed nucleus. This is the nucleus you can see here. It's very pale. You may not appreciate if you are not used at looking to screening such slides. And red cytoplasmic granules, again, you may not be able to appreciate until you look at this slide several times for you to be able to pick those out. But this is what we usually see under the microscope for a patient to be given a diagnosis of infection with Trichomonas vaginalis. We also have Interamoeba histolytica. You can have this accidentally in the pap smears when you are screening pap smears. So a patient may just be having other problems, but when you are screening, the patient could be having, she has cervical cancer, she comes for screening, but when you screen, you come across Interamoeba histolytica because, of course, we know the anatomy of the female, and it's a contaminant from the anal region. So we can, if they do poor wiping, usually they infect themselves with the Interamoeba histolytica, and they measure 10 to 60 microns with a small single round nucleus with a distinctive karyosome, thick beaded nuclear membrane, bubbly cytoplasm with ingested red blood cells. So these are the organisms, the Interamoeba that we are talking about. So many of them in the background, then we are having inflammatory cells in the background. What about schistosoma hematobium? Yeah, I've already mentioned about those with lateral spine and those with terminal spine. This is schistosoma hematobium, one of the slides. I usually like talking about students' work because now we've not copied this from the internet, courtesy of Eunice Rono et al. She was able to identify schistosoma hematobium in a pap smear. So it's important to know that we laboratory professionals play a critical role when it comes to infectious diagnosis for us to be able to give out such like a diagnosis, not really waiting for histopathological diagnosis. We can be able to do what we must do in our capacity for better patient management. We also have enterobius vermicularis, the ova of the organism is sometimes found in cervical smears. Sometimes, and the eggs are elongated, oval in shape. They measure 50 to 60 micromium in length by 20 to 30 in width and are characteristically asymmetric about the long axis being distinctly flattened on one side. So we are having enterobius vermicularis, and when we do cytology, we can also come across such. And when we come across such, we also report that the patient is having enterobius vermicularis. Oh, sorry, I have an error. I wrote enterobus. It's enterobius vermicularis. There is a typo error there. Okay, so after we've looked at the infectious and others who are not even infectious, sometimes people say vaginosis is infectious, others say it's not. We categorize them as non-infectious, nevertheless. And there is no research that is backing the aspect of saying that it is truly infectious. So let's look at the non-infectious agents and cytological changes. And this I'm just giving you an overview that we can see autoimmune and inflammatory conditions. This we can also use cytological techniques to say a patient is having an autoimmune disease or an inflammatory condition. An autoimmune immune disease, for example, thyroiditis. So with thyroiditis, we usually see lymphocytic infiltration with plasma cells and characteristic Hartwell cells changes in the thyroid cytology. So when an FNA of the thyroid is done, a cytologist or a cytopathologist will be able to identify or diagnose thyroiditis by virtue of the presence of Hartwell cells in the background, the characteristic Hartwell cells, and the lymphocytic infiltration. So then a patient is given a diagnosis of thyroiditis. Rheumatoid arthritis, yes, it can also be diagnosed on cytological techniques because then we are able to demonstrate rhagocytes. And rhagocytes are neutrophils with cytoplasmic inclusions. And of course, decreased complement levels. Now, decreased complement levels comes in immunology. You can see how cytology is relating with every other discipline. It does not operate on its own. And we have malignancy-associated changes. I said that this we will be able to discuss at a later time, but it's important to note that also in cytology, we are able to demonstrate the presence of cancers or malignancy-associated changes. And in that, we usually see tumor-associated inflammation, and you can also be able to demonstrate secondary infections, especially in immunocompromised patients with malignancies. We have those patients who have secondary infections. They have cancer, and then they are having secondary opportunistic infections that can be demonstrated on cytology or cytopathology. Okay, so it's important to note, we mentioned that we want to know from this session, we should be able to know that we also have strengths and challenges. So from my opening statements, I talked about the advantages of cytology, and here now I'm giving you the challenges or the limitations of cytology. Just like any other testing technique, cytology is not 100% correct or does not give 100% right diagnosis. And that is due to the factors that I already mentioned. So we have got challenges and limitations that pertains sample quality, the diagnostic accuracy, and limited information. For cytology, we must always have enough clinical history for the patient, all the information of the patient for us to be able to make a meaningful diagnosis. So if the clinician is not giving you some notes to help you to at least focus on a particular clue, to guide in the diagnosis, it becomes very difficult. So in that, if the sample is poorly collected, we will not get meaningful diagnosis. And if the sample is inadequately processed, again, we will not have a diagnostic accuracy. We are again prone to have false negative results. So cytology, you may get false negative results, or you may get false positive results, depending on the kind of specimen that you are handling. And now, having looked at the limitations or the area, the false positive or false negative, what do? We usually embrace the use of other techniques to be able to back up our diagnosis. If we are not very sure of what the diagnosis is, then we recommend for further testing as an adjunct, or we incorporate a specific technique for us to back up our preliminary reports. So we have molecular methods, which are PCR-based detection methods, and we also have in situ hybridization, next generation sequencing, and we also have immunocytochemistry. So all these can be able to help us to make or to increase our diagnostic accuracy. So if we want to improve on the diagnostic accuracy, we will always embrace the use of, or we incorporate other molecular techniques or immunocytochemistry techniques for us to be able to make a meaningful diagnosis. And for those infectious agents, we can also use microbiological techniques. If we want to know which kind of species, then we have to do culture and sensitivity. I forgot to mention in this slide that we also incorporate microbiological detection techniques that can always guide us to know the specific types of or species that we are dealing with if we are not able to identify them using cytology. Okay, to come to the conclusion, it's important to note that cytological examinations of infectious and non-infectious agents remain a cornerstone of diagnostic pathology, requiring integration of morphological expertise. So you have to be an expert in morphology. At least you have to have those skills of identifying those key features that we talked about to make a diagnosis, and you must be technically proficient for you to be able to give a diagnosis, and you must have clinical correlation information so that you can do clinical correlation to achieve accurate diagnosis and optimal patient care. So all the three combined will be able to assure us that we are making a good diagnosis. And as diagnostic technologies continue to evolve, cytology remains or maintains its essential role in rapid, cost-effective pathogen identification and disease characterization, adapting to incorporate new methodologies while preserving its fundamental diagnostic principles. It's important that we give out diagnosis to our patients because they are timely, and the patients are not going to spend a lot of money to do maybe a molecular aspect of a herpes simplex, the sequencing and the likes, if you are able to demonstrate cytologically that you have seen herpes simplex virus or cytopathic effect in a slide that you are examining. And the last one, the integration of traditional morphological assessment with modern molecular techniques represents the future of cytological diagnosis, providing unprecedented diagnostic accuracy while maintaining the rapid turnaround times that make cytology an invaluable clinical tool. And indeed, the turnaround time is key, and it comes in handy because if you delay patient diagnosis, then the management is delayed. If you delay the management, the end result for that patient is not always good. So thank you very much for giving me an opportunity, and thank you for listening to my presentation. That is the end of our discussion.
Welcome, Daktari. Thank you very much for this wonderful presentation. I'm sure that the entire participants in this webinar would have all stood up and clapped for this wonderful presentation. But I hope that they'll be able to show, and actually you can see on the chat, Alfonso Cheng is saying very informative presentation, and there are a lot of claps there, and thank you very much. At this juncture, I'd like to go to the questions that our participants have asked. First of all, many have appreciated and they continue to appreciate. Dr. Wilfred Gatua has actually appreciated and has commented, wonderful presentation. Thank you, Dr. Josephine. That's very great. Bernard Onduru has also appreciated the presentation, which is very good and of high standard. Bernard is just having one request that please is now calling you for a next presentation, of which will coordinate this very perfectly. Is yearning to hear about sample collection, preparation, and sending processes and procedures. So that will do. We will conduct this in our next session with Dr. Josephine. Agri Mogire is asking a question. What is the cause of colorectal cancers? Yes, Dr. Daktari?
Come up
If you
again,
can hear
please.
me. What is the
Yes.
cause of colorectal cancers?
Okay. I was avoiding talking about cancers, but it's okay because we are in a webinar. We will take the question. Thank you very much for that concern. The cost, you mean as per like how much it costs or not?
Yeah,
How much it costs
Agri
from
Mogire seems to be seeking to know the cause of colorectal cancers, one of which there's usually no specific cause. Various factors can cause colorectal cancers, and I think we'll also have another session for specifically colorectal cancers on the same, just as Dr. has just guided.
Sorry, George.
Yes.
Sorry. I thought you were talking about cost. Cost or cause?
The cause.
Or what causes
What causes
or the risk
colorectal
what causes?
cancers?
Yeah, that we can do it at another level if Agri, if you may allow.
Yeah, sure.
Thank you.
Yes, so another question now for the aspirates. Lydia is asking, how long should an aspirate remain in room temperature for it to be still viable for cytological studies?
Okay, so thank you, Lydia. Thank you, Lydia, for that good question. Aspirates, when we talk about aspirates, we need to be able to categorically distinguish it, give a distinction, because we have different aspirates. If we talk about fine needle aspirate, usually it's just placed directly on the slide and fixed and stained, and it's archived. You can stay with the slide for 5 to 10 years, depending on the standard operating procedure in your facility. But if you're talking about now preservation of the aspirates, let me try to understand you. Maybe you are talking about pleural fluid. Pleural fluid for us would be an aspirate, a pleural fluid or peritoneal fluid or any other fluid specimen. Those ones we don't call them aspirates. Aspirates are when you are doing a fine needle aspirate, you are using a surgical procedure, a clinical procedure, I mean. But if you want to, if you are thinking of pleural specimen, you are thinking of peritoneal specimens, we have different ways of making that you are storing them to maintain cellular morphology. For pleural, peritoneal, and pericardial, those are what we call effusions. So effusions, you have to keep them at you have to put them in a refrigerator at 4 to 8 degrees for 24 to 48 hours. Sometimes you can still keep them in the refrigerator for even up to 72 hours. So why a longer period is because they have what we call a high protein content specimen, and the protein content there cautions the cells. So the protein acts as a tissue factor for the cells, meaning that the cells will not degenerate even up to 48 hours or 72 hours. But if you have specimens like urine, you have CSF, those ones you will have to refrigerate them in the refrigerator for a shorter time, because if you don't, for example, the urine, if you do not process them immediately or within a specified time. Some of the books talk about 1 hour, but it cannot take you cannot preserve urine for 2 days or more than a day for you to get accurate results. So you have to make sure that you are within 1 hour. You process your specimen within 1 to 2 hours of collection, so that you do not have degenerated cells. Why?
Wonderful.
Because you may have what is it? This is a enzymatic action or bacteria that can be able to degrade your specimen. So we have to categorize our specimens in different categories: those with high protein content, those with high mucus content, and those with high levels of acidity, hydrochloric acid. Like, for example, the gastric content, you will not store them. You will have to process them immediately, because if you don't, the cells are going to be degenerated with enzymatic action because of the enzymes that are present in the GIT. So you have to group your specimens in different categories for you to be able to know how you preserve them for accurate results.
Great.
You okay?
Great. Thank you very much for that. And I hope that Lydia Kyoge has got a full dose of answer to the question that she asked. Another question is within the area of herpes simplex virus investigation. So when one is to investigate herpes simplex, Washington Dega is asking, what is the sample of choice? Is it a point of exfoliation or aspiration? Herpes simplex, Dr.
Thank you so much, Washington, for that question. For herpes simplex infection, it depends on where the symptoms are. If it is from the skin, if the patient is having some blisters from the skin, you can do scraping. You can do skin scrapings. But if the patient is maybe having a history of stillbirths, she's telling you that I've been having stillbirths and we don't know the cause. Herpes simplex virus causes stillbirths in women. So with cervical smears or pap smears, or with high vaginal swabs, you can still demonstrate the presence of herpes simplex infection. So you can use skin scrapings. If the blisters are on the skin, you can use pap smears, and you can use vaginal swabs.
Great, thank you. We have Miriam Mutua. Miriam Mutua is now referring to the slides that you used to demonstrate this cytomegalovirus and HSV. Miriam is asking, are those cervical smears the ones that you use to demonstrate CMVs and HSV?
Yes.
Cervical smears, good. Thank you very much.
Yes.
So Miriam Mutua, those were from the smears that were taken from the cervix. And then Stephen Otoi is asking, can you show the various intraepithelial lesions that correspond to different grades of cervical cancer? Can you show the various intraepithelial lesions that correspond to different grades of cervical cancer? I think
Thank
this
you
is
so
not
much.
straightforward. Yes.
Thank you so much, Stephen, for that wonderful question. Yes, I could and I can demonstrate the various lesions, types of lesions that I know you are interested in. However, in this particular session, we were talking about infectious and non-infectious diseases. But given time, we can be able to discuss that when we shall be talking about cervical cancer diagnosis. That's where now we shall be able to show you different lesions, for example, low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesion and carcinoma in situ and squamous cell carcinoma. That is a big topic on its own, and I request that we can do that at a later time. Alternatively, if you still have time, the moderator today, then I can be able to go back and fish out those slides because they are archived somewhere. But for this presentation,
Okay.
we narrowed ourselves to there. We didn't go the way of the cancer diagnosis, but I'll be glad to share with you the same if I'm given an opportunity. Thank you so much, Stephen.
That's wonderful. Thank you very much. Now, one of our attendees is having a case study. I mean, something that one of his or her client passed through. I'll just read it as it is. I have a client treated for recurrent UTIs. Urine culture was done and Proteus species isolated. The patient was treated with levofloxacin for 5 days. Yeah, the patient was put on antibiotics, yes, but still experienced itchiness after sexual intercourse. Urine examination was done again, and there were presence of pus cells. So what do you advise on this? Could it be one of the viruses? So the laboratory practitioner is now wondering about this condition. Could it be CMV or the other viruses that you are talking about during your presentation concerning the condition of this client in this study, in this case that has been presented? Dr.
Yeah, thank you so much for that concern. It's a very good case and an interesting one that we would want to follow through. So when it comes to itchiness, Trichomonas vaginalis causes the itching of the vulva. When it comes to bacterial vaginosis, the same. If the patient has been given antibiotics and she's not able to respond, you can always advise the patient to go for further testing. Let the patient have other tests. Let the patient have a pap smear done and be able to see if she's having any other concern. Because sometimes people concentrate on the UTI aspect, but the patient could be having something that is more than the UTI that we think about. We may not say that it is herpes simplex or BV or trichomonas infection by word of mouth. We have to demonstrate. You remember that laboratory is evidence-based. We cannot say it may be, these are just clinical information that we are getting. So for us to be able to say that a patient is having this other herpes simplex virus or BV, we have to do a test. So we have to collect pap smear from the patient and try stain it using Papa Nicolau and try to see if she could be having all these other viruses or bacteria that are giving a problem. So as per now, as we're talking, I may not be able to tell whether it is Trichomonas vaginalis or any other infections or infectious agents until a pap smear is collected and evaluated. I hope that helps you.
That's
So just
wonderful.
refer patients for further testing. Thank you.
Great. Thank you very much. Next, you presented and talked about hyperchromasia. Now, Isaac Musyoki is now asking this question. How can true hyperchromasia be differentiated from one that arises due to a staining error?
That is a very
Yes,
good
Dr.
question. Isaac Musio, thank you very much for that question. Hyperchromasia could be caused, yes, true, as you speak, as you're saying, it could be due to overstaining using maybe hematoxylin. The slide can overpeak because of the staining time, the staining length. It may not be very possible for you too, but you can, if you are an experienced cytopathologist, you can be able to know that this hyperchromasia is not due to the staining process. It's a biological aspect, meaning when you are having when you're looking at the microscope for biological aspect of hyperchromasia, it means that the patient is having high number of chromatin content in the nucleus, and that's why you are having the hyperchromasia because of the more number of chromatin content in the nucleus. That is the time you get hyperchromasia. And even staining, yes, you can have the hyperchromasia, but you'll be able to see adjacent cells. If you look through the slide, you'll be able to see that there is a trend. From field A, I had this number of cells looking hyperchromatic. You go to the next field, they're all looking hyperchromatic. You go to the third field, they're looking hyperchromatic. You will automatically know that it is the staining process and it is not from the issue of having high number of chromatin content in the nucleus. So it's not an abnormality. So yes, you can tell that this hyperchromasia is due to overstaining, or it is due to a biological process. By scanning through the slide, you can be able to see a trend of the staining characteristics. So even before you take a slide to the pathologist, that is what you are supposed to do as a laboratory professional. You quality check your stains before it goes. So if you're seeing that your slide is hyperchromatic, the whole of it, all cells are hyperchromatic, it's not possible that all slides have cancer cells. So you will just know that you are having hyperchromasia that you have introduced during your processing. You overstained. But if you see few cells having hyperchromasia, you move through the field, the whole slide, you just see 1, 2, 3 cells having hyperchromasia, and then you will know that it is a disease process.
Wonderful. Thank you very much.
That.
There's so many questions streaming, and time is also running. Cornelius Masila, I really appreciated you, Daktari, for the insightful presentation. Our next question is also very relevant in our labs. Now, we have Papa Nicolo and HND staining. Now, Hilary Toom is asking, which criteria is used to choose the type of stain to use in staining between Papa Nicolo and HND?
Thank you, Hilary, for that question. For all pap smears, that is for pap test, cervical cancer screening, we use Papa Nicolau. That is the choice. That is the only stain that you can use to stain Papa Nicolau specimens or pap smears for cytological evaluation. But when it comes to other specimen types, for example, fine needle aspirate, you can use both. You can use Papa Nicolau and you can use hematoxylin and eosin. So when it comes to FNS, fine needle aspirates, of maybe breast, lymph node, thyroid, and the others. The one who is reporting the slides, the pathologist will always have a prevalence. They'll tell you, comfortable reporting my FNA breast or FNA thyroid that have been stained with H&E. There are those who will tell you, please, I will need a combination of two. I will need Papa Nicolau and I will need H&E, and I will also need a Romanowski stain. So some of the pathologists have a prevalence for the three: Papa Nicolau, hematoxylin, and Romanowski stain. The three slides stained with those slides, depending on the pathologist prevalence. There are those who prefer H&E. There are those who prefer Romanowski stain. So that is dependent on the pathologist when it comes to fine needle aspiration material. But when it comes to other specimens, pleural fluid and all other urine, sputum, others, you can now choose to use Papa Nicolau, because Papa Nicolau will give you crisp appearance. You are able to see the nuclear characteristics very well when you use Papa Nicolau. But please remember that for cervical smears, don't stain using H&E. Use Papa Nicolau or PAP reagents. And for all other specimens, you can be able to use H&E Romanowski stains. Because with the Romanowski stains, again, you are able to see the cytoplasm. Remember, we talked about the nucleus and we talked about the cytoplasm. So if you want to have a good look of the cytoplasmic features, then you use Romanowski stains. You have to input a slide. You have an extra slide so that you look at the cytoplasmic content of the cell. And then H&E, now the hematoxylin, you'll be able to see the nuclear content, or the PAP, you'll be able to see very good features of the nucleus. So I think I've tried to expound on the same.
Yes, you've actually done it well.
Thank you.
Emma Mwangi is also having a concern about special stains. Now we have a pap smear slide. So Esther Mwangi is now wondering, after now staining this slide, and there's some special staining that is needed, do we demount and destain the pap smear slide?
This is Emma. So,
Yes.
So this is a pap smear, meaning that it's a cervical smear, right? If that is the perspective, then I can be able to handle this. If you only have one slide, because when you do a pap smear and you find that you are having maybe HSV and you're not very sure whether it is HSV, but you're seeing the features and you think it is, and you want to do other, or like, for example, if you want to do the Congo red and the other slides, not for pap smear, you cannot do special techniques because we are not interested in the fungal elements. For pap smear, actually, you can see the Candida species. So special stains comes in later when you want to demonstrate some mucin, you want to demonstrate others. But assuming that that is the same slide that you have and you would want to demonstrate the fungal elements, yes, you can do this staining. But I've not seen where we are doing special stains on pap smear. And pap smear here, I refer pap smear as a specimen that has been collected from the cervical epithelium for cervical diagnosis. But should there arise a need to do further testing, you can distain the slide, but you have to make sure that then you have archived the results. The primary diagnosis, you have to put it in somewhere so that you have a backup. If this is the only slide and they may want to have a second opinion and you have already distained and done a special stain, you see now somebody may come and say, can you give me my slide for a second opinion? You won't have that particular slide for a second opinion. So if you have a place, if you're doing digital cytology, digital pathology, you can be able to archive the report. You put your reports are supposed to be in the iCloud if you're doing digital cytology, so that you have the preliminary results of this pap smear. And if you subject this pap slide to any other further testing, now you'll be having the results, the primary results that you will compare with. So, but it will depend again on the person who is on the bench. What is it that you want out of this pap smear slide?
Great. There's one more concern from Dr. Wilfred Gatua. Is saying, kindly comment on the appropriate diagnosis of cervical cancer using cytological smear vis-a-vis HPV molecular testing. Appropriate diagnosis of cervical cancer using cytological smear vis-a-vis HPV molecular testing.
Come up again, please.
Kindly comment on the appropriate diagnosis of cervical cancer using cytological smear vis-a-vis HPV molecular testing.
Okay, so when it comes to cervical cancer diagnosis, we have the pap smear test that we usually do that has been in place for more years, decades of years, a long time in practice. And this technique was introduced in 1940s by Papa Nicolau. And where it is being practiced in countries where cytology is being practiced, screening is done using pap smear. There is evidence of having a reduced burden of cervical cancer. So techniques usually come every time evolving. So from pap smear, yeah, people now have come up with HPV DNA testing. But having HPV DNA testing does not qualify somebody to say that a patient is having cervical cancer. So it is used alongside pap smear. So what happens is if a patient is positive for HPV DNA testing, this particular patient will be told to do a pap smear or do a biopsy to confirm if the HPV has caused the cytopathic effects. So for cytology, we usually see the cytopathic effects that are there because of the presence of a virus, because this virus integrates itself to the nucleus of the cell and multiplies. So by the time a woman is showing symptoms of cervical cancer, if at all she develops cervical cancer, it will have taken 20 to 30 years. So the essence here of HPV DNA testing, they're using it quite often nowadays so that a woman is told you're testing positive for HPV. So what next? Having HPV exposure does not warrant one to say that a patient is having cancer. Here we are saying it's positive, a patient is likely to develop cervical cancer. So what do? We start managing the patient. So we cannot say that HPV is the diagnostic tool for cervical cancer, but a combination of HPV testing, pap smear, and biopsy. Biopsy is the gold standard of pap smear. So for detection of cervical cancer. So if I say as a cytologist that the patient is having cervical cancer, I would always recommend a biopsy. So a biopsy is more superior than cervical cancer.
Wonderful.
Yes.
Now, I can see time has passed, and I can see very many questions still, and many people are actually appreciating your presentation, which is very good. We'll not find time to go through all these, and at this end, we need to do a summary to finalize today's webinar. There are quite a number of attendees who are asking for slides. Kindly note that this session is being live streamed on our YouTube channel. Kindly follow our YouTube channel so that you can watch these sessions that we usually have for reference purposes. For further learning, kindly watch the YouTube videos that we live stream. Number two, to our participants, ensure that your attendance is 60%, at least 60% of the duration of the entire webinar for you to qualify for 3 CPD points. That is mandatory and is pursuant to the regulations by the board. And in addition to that, when registering, let us use the current M-Pesa text. Let us paste the current M-Pesa text for that we've used to pay for the webinars when you are looking for the 3 CPD points. Let us avoid editing the M-Pesa text when registering. Without much ado, this webinar has been a success. And on behalf of LMSK, we really appreciate the medical laboratory practitioners who have participated in this session. And we appreciate Dr. Josephine Rioki for taking part in this. You can actually see that clinical cytology is quite wide, and what has just been presented, we can say that is just an iceberg. There are quite a lot that will still engage our presenter to present on, for example, the sample collections and all that, because many participants are having a lot of concerns in regards to such. So there's still more time for that. So at this point, I'll call upon our presenter, Dr. Josephine Rioki, just to give a closing remarks, and then we'll end this session. Dr. Josephine.
Thank you so much, George. And thank you to every one of you. I'm so humbled to have interacted with you, and so happy, excited that I was hosted by LMSK. Some of them being my students prior, and others very good friends. So as George has said, cytology is very, very wide. That's why I just narrowed down to something, as just a portion of the same. But if we can get time, we can look at HPV DNA testing, not HPV actually, HPV and cervical cancer at one point, so that we can be able to understand, because HPV, having an exposure of HPV does not mean that a woman is developing cancer, but there is a likelihood of development of cancer due to persistence of the high-risk types. And the HPV DNA testing alone cannot suffice. So you have to do quite a number of tests, HPV DNA testing, pap smear, and we call them co-testing. So you can have colposcopy and biopsy and HPV DNA testing for you to be able to comfortably say that a woman is having cervical cancer. So if I get another opportunity, we can be able now to look at those aspects that our members wanted more clarity on, like the lesions that we talked about, the high grade, the low grade. So I avoided the cancer bit of it because it's a wide area. So thank you very much for giving me an opportunity, and always humbled to give another talk if there is time. God bless you, and thank you for listening to me.
Welcome, Dr. We are also thankful for your time, and also the moment that we've had during this session. I would actually like to inform the participants that Dr. Josephine Rioki is my former lecturer at the University of Nairobi, and also my former supervisor. and you can actually attest of her prowess in this area. To this end, on behalf of LMSK, we've come to the end of this session, and let us meet during our next webinar. Thank you very much and have a wonderful weekend ahead. Thank you.